Hi everybody, this is Professor Stevens. Today I want to talk about restrictive respiratory disorders, which is chapter 23 in our textbook. So within this particular unit, hopefully you have already gone through the obstructive respiratory disorders, in which COPD was the main focus for our respiratory system disorders. So the ones that are here are a little bit more minor disorders. Some of them are more some of the manifestations that you might see as a result of other underlying disease conditions, and then some more infectious diseases like pneumonia and tuberculosis as well. So in the obstructive respiratory disorders, we saw that the problem was that the tube was blocked. There's something that is obstructing airflow. Here, in chapter 23, all of these disorders have something that is preventing the lungs from being able to fully expand. So that could be a problem where you've got, for example, fluid inside of the lungs, or fluid inside of the pleura, or something that has damaged the lung tissue or the chest wall that prevents the lungs from being able to expand out, so that you can't open up that chest cavity to be able to get air in for gas exchange. So within this within this chapter, I have you look at a few different respiratory system disorders, but they all will have some similar characteristics, just like the obstructive respiratory disorders did. So because the lungs can't expand, you would expect the volumes now to be reduced across the board. So a decrease in things like vital capacity and residual volume are going to be characteristic of a number of these respiratory disorders. And then again, depending upon the condition, just like the other respiratory disorders, low O2, in many cases high CO2, and then you can see here respiratory alkalosis can happen for some of these respiratory disorders as well, but we will worry about that when we get to the acid-base disorders in chapter 25. So the first one that I have you look at is ARDS, acute respiratory distress syndrome, or sometimes adult respiratory distress syndrome. This is basically a series of conditions that result in respiratory failure suddenly and often traumatically, and as the name suggests, in adults more than in infants. So what happens is you have something that is damaging that respiratory surface where the alveoli meet the capillary, and as a result you get this fluid that basically infiltrates into the alveoli. It's full of a lot of protein, which then causes severe respiratory distress and has the potential to be life-threatening. But usually this happens as a result of something else, some other sort of underlying condition. So this could be potentially something at end of life, but in many other cases it's something due to severe trauma to the chest cavity, for example, septic shock. If you were to aspirate stomach acid, which can be very common in patients that are very weak, that have been hospitalized for a while, if they end up vomiting, for example, or anything like that, you can get that in the respiratory tract. Now you have this acid that's in there that can trigger this. Shock can trigger this. Different types of shock can do this as well. So this is a relatively common situation that, again, like I said, is life-threatening. And you can see here, the title suggests what the problem is, that you end up with atelectasis, or lung collapse, where the alveoli stick together and then they can't reinflate. Now you have no surface for gas exchange. So particularly in ARDS, so as we've damaged that respiratory surface between the capillaries and the alveoli, those capillaries become very permeable to fluid. That fluid leaks out, gets into the alveoli, and then they fill, and as a result you can't get gas exchange. You end up with pulmonary edema as a result that happens very, very quickly, and this massive inflammatory process that then leads to acute respiratory distress and potentially can be fatal. On the other hand, infant respiratory distress syndrome is a little bit different. It's similar in the way that it can manifest and then be life-threatening as well, but the reason that it occurs is a little bit different. This is one of the reasons that we kind of have a cutoff point for neonatal survival, that we don't really see very, very young infants actually making it because of not having a well enough developed respiratory system in order to be able to survive outside of the womb. So right now it's about 22 weeks or so is the minimum amount of time that an infant needs to be inside of the womb in order to be able to survive outside of the womb. So what we see are two different reasons that this occurs. This is what is going to predict whether you can get a neonate to survive outside of the womb at that time. The first is whether or not surfactant is present. In infant respiratory distress syndrome, the primary cause is no surfactant or very little surfactant. This is a coating inside the alveoli that prevents them from sticking together and allows them to stay open. This is a developmental issue because in the womb, fetuses do not need to use their lungs. They get oxygen from mom. So the lungs are not well developed until towards the end of development inside the uterus. And so there's no need for surfactant to be present at very, very young stages of development. And so without surfactant, the alveoli stick together and then you don't get gas exchange occur. And so as a result, the infant would have to generate very high pressures in order to basically blow open the alveoli each time that they breathed in, and they just don't have the strength to do that when they're that size, and so as a result, they end up in respiratory distress. The second cause is related to the pulmonary blood supply. Again, because the lungs are not needed for gas exchange in utero, the pulmonary blood supply is very reduced. They're very immature. They don't have the capillaries available to pick up gas from the lungs. So on top of the alveoli not having any surfactant to stay open, you don't have the capillaries that are there in order to be able to pick up gas once that baby now suddenly emerges from the womb. And again, this is just a developmental issue. And so this is why you see premature infants having to stay at the hospital basically throughout the remaining term of their pregnancy to allow their body to be able to develop those components associated not just with the respiratory system, other systems as well, but in particular, obviously oxygen is needed by all cells. So that's one of the main determining factors for infant survival as a neonate is, do they have a developed enough respiratory system to be able to handle living outside of the womb? And if not, they end up with IRDS. Pneumothorax. This is a situation where you get air collecting in between the linings of the pleura. Remember, the pleura is a double membrane that has a little bit of fluid in between. And so you can end up with air getting into the pleura, either from the outside. For example, if you were stabbed in the chest, that could puncture that outer or parietal layer of the pleura, and then air could get in from the outside into the pleura. Or you could have a situation where you have a problem inside of the lungs that erodes that visceral lining of the pleura, the inner lining of the pleura, and then air escapes from inside the lungs into the pleura. Or you could have something where it goes through both layers of the pleura, and then air collects inside that space. So what happens is those pleura are supposed to be close together, but now they're full of air, so they begin to separate. Now there's no space for the lungs to expand, and that air collects inside that pleural space, and that air gets bigger and bigger, and it shifts all the contents inside the chest cavity over towards the other side, and then compromises the heart and the other unaffected lung. So there's different types of pneumothorax. So you can see primary and secondary pneumothorax. Primary is like a spontaneous pneumothorax, not as well known as some of the other types. Secondary pneumothorax could happen if you had something like lung cancer or pleurisy or something like that, where you have an underlying respiratory disease that causes a space to appear in the pleura, and then you develop a pneumothorax. The one that we typically see in all of those medical shows are tension pneumothorax as a result of some sort of a trauma that penetrates through the pleura, and then you end up getting air collecting in there as well, and this is a medical emergency. The other pneumothoraces as well can be problematic if enough air gets in there, but usually it takes a while and it accumulates very, very slowly, and so it's not as nearly as dramatic as in a tension pneumothorax from a major injury. So what happens is, as I said, that air builds up and separates the two pleural membranes and then begins to push everything towards the unaffected side. So you get this tracheal shift towards the opposite side that hasn't been affected, and everything gets compressed. Now you affect the ability of the heart to work and blood to be able to get to the lungs and to be able to pick up oxygen. But you worry about atelectasis, you worry about the lung collapsing as a result of it not being able to expand and get enough air. So it shows you here in a much nicer picture than I could ever draw. If you look at the picture on the top where it shows a spontaneous pneumothorax, the lung that you can see on the right side of your screen has normal pleura. You can see they're close together. But on the left, because air has escaped from inside the lung into the pleura, now there's a lot of air in the chest cavity. There's no space for the lung to expand. And so as a result, the alveoli can begin to collapse, and then everything begins to shift. As you breathe, more and more air gets trapped inside that space. And you can see in the picture in the bottom left that actually the outer layer of the pleura has also ruptured, causing more air to get in, and then everything shifts over to the other side. So this is where you get that sucking chest wound sound if the penetrating injury has come from outside of the body, as air is getting sucked in during breathing. And so you can put like a piece of plastic over there to act like a valve to prevent air from escaping during breathing patterns as well. So this is one of the characteristic manifestations that you see with the pneumothorax. As I mentioned, if they're small, like you see in some of the primary pneumothoraces and even some of the secondary ones, you may not even notice it until it becomes more and more severe. But because it can cause severe respiratory distress, it'll trigger the stress response. So, of course, tachycardia is going to be there, especially to help try and increase oxygen delivery. And then the lung that's affected, you're not going to be able to hear breath sounds because it can't expand to breathe. It's going to be very painful. You're going to get shortness of breath and all of those things as well. If blood is also in there because you've had trauma, it might just not be a pneumothorax. It could also be a hemothorax as well. It doesn't have to be just air. You could get blood collect in there as well. Sometimes if it was an infection, you can get pus and things collect. It doesn't just have to be air. But you can see that tension pneumothorax and a large spontaneous pneumothorax can be potentially life-threatening, because once that lung's collapsed, that's it, and everything's shifting. You're compressing the components inside the chest cavity. There's nowhere for them to go, so you're putting the heart and the other good lung at risk as well. A pleural effusion is where you're getting fluid collect inside that pleural space, not blood, but fluid from like inflammation, or if you had an infection, you can get pus, like empyema, collecting inside that cavity as well, and then you would need to drain it out. The effects are similar as to having air inside that space, so the lung can't expand because of the fluid that's there, and it's going to compress the structures that are within the chest cavity as well. In terms of infections, I have you look at two infectious disorders, pneumonia and tuberculosis. Pneumonia is an infection caused by a variety of different organisms. You can have bacterial pneumonia, viral, fungal pneumonia. There's all kinds of different things that can trigger this. You can see even aspiration of stomach contents can lead to the development of pneumonia, aspiration pneumonia as well. And just like any other infection inside the body, this is now happening inside the alveoli. So you begin to get fluid collect inside the alveoli, which is going to obviously impair gas exchange. This section can get really detailed, in which you can go through and you'd have to compare and contrast the different manifestations associated with bacterial, viral, and fungal types of pneumonia. I'm not going to make you do that at this point in time. I just want you to be aware of the different types of organisms that can cause pneumonia and the general clinical manifestations associated with pneumonia. And then as you progress further, you'll be able to differentiate some of those manifestations once you get more into core and you can look at the different types of organisms in more detail. And hopefully you looked at this a little bit in microbiology already as well. So you can also classify pneumonia not just based on its causative organisms, but also where you got it. So was it out in the community, or did you pick it up in the hospital as well? High-risk populations are similar to what you see for other infectious disorders, but again, if you think about where you can pick up this type of pneumonia as well, obviously you see seriously ill, high hospitalized patients, things like that, are going to be at a greater risk for this. Anybody who doesn't have the ability to be able to clear the respiratory tract very well, if you get secretions and things like that in there, that can lead to the development of pneumonia as well. And anybody who's immune compromised, of course, is always at risk for everything. So normally your respiratory system has a lot of defense mechanisms associated with it, because everything that you breathe in, there's always particles of something or other, mold or bacteria or dust or whatever. The respiratory system always has to be on alert to make sure those things don't cause any further problems inside the body. And so what happens is, for some reason, your pulmonary defense mechanisms are compromised. And so these organisms are able to get in there and then cause the inflammatory processes to occur. And then as a result, this inflammatory exudate that happens from the process of inflammation, just like we saw back in chapter 9, begins to fill the alveoli with fluid and then reduce the area available for gas exchange. Depending on the causative organism, it can affect the lung tissue as well, especially in like fungal pneumonias as well. It can cause consolidation to occur as more and more alveoli fill. Entire lobes can be impacted. The gas exchange might not be possible as well. Viral pneumonia, you can see, doesn't typically produce that kind of fluid that you see in some of those others, so that's one of the main differences between them. But typically, if you think about somebody having fluid collecting inside of the lungs from an infection process, you usually think of pneumonia. So depending upon the causative organism can determine some of the manifestations as well, but as a result of the fluid, you typically would expect to hear crackles, dyspnea, things like that. Fever is very common for many of the different causative organisms, not all, but for a lot of them as well. You would have a cough because of the fluid that's there, and if it's a bacterial infection, you would expect purulent sputum. Remember, purulent means that there's pus present inside of the sputum as well. And then I also have you look at pulmonary tuberculosis as well. And as you already know, tuberculosis is very common in the population. It's one of the things that they're worried about you being exposed to while you're going into the healthcare field, because it is very, very common, not just inside the hospital population, but in the general population as well. High-risk individuals include the same that we just saw as before. If you've had a prior infection, if you're immunosuppressed, and then if you're living in any sort of crowded conditions. So this could be prisons, group homes, detention facilities, long-term care facilities, anything like that where you have a lot of people living together, that can happen. Elderly. This is particularly a problem because we've been treating it so long with the same antibiotics. We have drug-resistant forms that exist. So this organism is very common. It's very prevalent in the population. We have drug-resistant forms that exist, so it's very difficult, to avoid being exposed to this at some point in your lifetime. If you're healthy, it's not really a big deal, but if you fit into one of these high-risk categories, you can be in a lot of trouble. The causative organism for tuberculosis is Mycobacterium tuberculosis. This is a bacteria. Excuse me, it's an acid-fast bacteria, so this is where your micro knowledge might come back into play if you remember using the acid-fast stain. It's one of the ways you can identify this. It is contracted by a respiratory droplet, and so this is where the crowded conditions come into play, and especially making it easy to pass it from one person to another, and then you get a drug-resistant form in there. It can be very, very difficult to get rid of. So usually what happens is you've been exposed to tuberculosis. If you're healthy, you might get some general mild flu-like symptoms. This is typically the manifestations for a lot of respiratory disorders, right? Whether we're talking about the flu or a cold, pneumonia, tuberculosis, everything seems to present with mild flu-like symptoms. So weakness, fatigue, malaise, lethargy, maybe a fever, those kinds of just general manifestations go along with that. And as long as you're healthy, you might fight it off and everything be good. The problem comes with secondary or reactivating tuberculosis later on in life. If you've had something that causes your immune system to be compromised, or you enter one of those high-risk categories, those bacteria that have been in there that you were exposed to long before, they have been there dormant and waiting for an opportunity to begin to divide. And so now you get this reoccurring infection that occurs, and it occurs with a much greater vengeance. So it causes much more damage to the lung tissue as well. It basically erodes the lung tissue and then begins to eat away and causes the major destruction of lung tissue, and then eventually is fatal. So what happens is these bacteria, after they have sort of become dormant, they can live and form these little what are called gone complexes or gone tubercles, which is where the name comes from. And this is why you have to have a chest x-ray done. You're looking to see, are the tubercles there? Do you have active tuberculosis going on? Do you have destruction of the lung tissue that's occurring? You've got these basically ready and waiting for a time when you might be compromised, and then you've got these bacteria that can then reemerge and then cause more and more damage. Clinical manifestations, like I mentioned, these mild flu-like symptoms, low-grade fever, cough, purulent sputum because of the type of organism this is, fatigue, etc. You would expect to see in many cases crackles as a result of the material that's collecting in there, and eventually areas will consolidate and it can erode through into the blood vessels, and you can end up with hemoptysis, a blood-tinged cough, sputum that happens as a result. Once the blood barrier has been eaten through, then you can end up seeing blood appear as well. If anybody's ever watched the movie like Moulin Rouge, for example, in the Victorian age and such, they called tuberculosis the consumption. If you ever saw anybody coughing and blood was appearing in their, handkerchiefs and such, that usually indicated that person probably had reactivating tuberculosis. Diagnose it obviously with a chest x-ray, as we said, and then your TB skin test. Hopefully everybody remembers that's delayed hypersensitivity, type 4 hypersensitivity, where they go through and inject the tuberculin, and then you've got to wait a few days to read it to see whether or not you have been exposed to tuberculosis. Remember, it doesn't tell you whether or not you had it, just that you have the antibodies to it. So it doesn't tell you current or prior infection. That's where the chest x-ray is going to come in. And people who've already had the vaccine for tuberculosis, which unfortunately is not very effective, but people have received the vaccine before, will also have a positive TB test, and they're going to have a chest x-ray as well. So those are the disorders associated with Chapter 23 and the restrictive respiratory system disorders. Remember, in this situation, we have disorders that are preventing gas exchange from occurring because the lungs can't expand, in many cases because of some sort of fluid or air that is preventing gas exchange or the lung expansion from occurring properly.